I hope that we've really gotten it across that we feel strongly that psychiatry and behavior supports can work together. You will see in most situations that the behavior services are first to engage, and this is largely related to the systems that support individuals. It's just a reality that there are fewer psychiatrists available, especially those that support individuals with intellectual disabilities, and their time is very limited compared to behavior services. It's really helpful that behavior service providers can quickly go in to the environment, observe the individual, and suggest, kind of quick things that can be done to modify the environment and approaches to manage unsafe behaviors while assessments are being conducted. Gather a lot of the same information during our assessments, which is valuable in the psychiatric assessment. We are in the business of really getting to know the individual, understanding their tendencies, their strengths, skills, cognitive capacities, and the potential functions of behavior, which can be really helpful when psychiatrists are trying to tease apart what behaviors could be related to an intellectual disability versus symptoms of a mental illness versus learned patterns. I did fail to mention this in the last slide, but behavior services assessments and plans include data collection procedures that are aimed at tracking the frequency, duration, and intensity of challenging behaviors, which give us and psychiatrists a good objective idea of how often challenges are experienced before, during, and after interventions. There are also situations where behavior services will take a step back and wait for psychiatric consultation. And there's some red flags that we may observe, which leads us to believe that some underlying causes would be better addressed from a psychiatric or a medical perspective. Red flags include things like rapid, unusual weight gain or weight loss, behaviors indicating pain, so wincing, holding certain body parts, a marked increase in self-injury. If we notice a really difficult time focusing, frequent inattention, extreme distractibility, impulsivity, and excessive level of activity that is sustained in settings and over a long period of time. Toilet training, if somebody's already previously successfully been toilet trained and now there's a new onset of bowel and urinary accidents, or nighttime urinary accidents. If we notice changes in motor or adaptive functioning or sudden changes in cognitive functioning or verbal skills, um, you know, marked changes in mood and temperament, so like extreme irritability, worry, avoidance, or explosive anger. Other things may include poor eating, poor sleeping, loss of interest in appearance. And with sleep issues, that could be, difficulty waking up in the morning, difficulty falling asleep at night, or falling asleep during activities throughout the day. And the reason that we would take a step back in this situation is that it's really important that potential medical issues are ruled out before we try to address behaviors. You would never want to try to teach somebody to cope with pain that could be addressed by a dental procedure, or designing a toileting program when the person just has a UTI and needs an antibiotic. And that's not to say that you need to wait for a BCBA to come in and request these additional, referrals. If you as supports notice any of these red flags, go to the doctors, get it ruled out. It's only going to help quicken the assessment process. And then once a psychiatrist is working with the team, behavior services can absolutely still be valuable in assisting with, psychiatric follow-up. We can assist with communicating the situation to the psychiatrist, giving insights into the context in which symptoms appear. We can objectively define symptoms and challenges so that everybody on the team can really agree on what's being discussed. Setting up data collection procedures, which is so helpful in monitoring effectiveness of medications. We can assist with developing PRN protocols, defining exactly when a PRN should be given. It really does need to be individualized. You don't want to be giving a PRN to an individual that bounces and vocalizes and sprints across the room when they're excited and happy, which could easily be confused for agitation. It's important to understand, those nuances. It's also very important that everybody supporting the individual gives the PRN in the same situations and that we're tracking the outcomes so we can evaluate its effectiveness. Is it working at all? Is it being given too late in the crisis cycle? Should it be given when we notice precursor behaviors because those very reliably end in physical aggression? Is it too effective? Is the individual sedated for hours and unable to participate in daily activities? Does the person de-escalate very quickly without medication? Is it worth giving them a PRN if we know that the crisis is going to be over in 5 minutes and the PRN takes 30 minutes to take effect? Having behavior services on board to help specifically and objectively describe the protocol is very useful. In terms of interventions, we sometimes have a tendency to think that mental illness means that we don't need to also focus on behavior interventions, or that behavior interventions aren't helpful for somebody with a mental illness. But as the series is really getting at, there's so much overlap between psychosocial interventions and behavior interventions. We do really need to consider teaching coping skills and building resilience. We need to be giving the individual the tools to manage their dysregulation and give opportunities to practice specific skills so that they can learn how to work through difficult situations. And if you've ever worked with a behavior consultant, you know that skill building is our bread and butter. Finally, behavior services can help support education for caregivers about the individual's diagnoses, their treatments, their psychosocial supports, and why they're important. And also having discussions about realistic expectations regarding the individual's capacity and needs. We can also play a pretty significant role in empowering the individual and their supports to work together to address their challenges and look to a more positive future. So let's move beyond the hypothetical and talk more specifically about case examples where psychiatry and BCBAs work together.